Hello and welcome. Thank you for joining us. I'm John Shin from Mass General Hospital in Boston. I'm here with my colleagues.
I'm Josh Patt from Carolinas Medical Center and Levine Cancer Institute in Charlotte, North Carolina.
And Rory Goodwin at Duke University, Director of Spinal Oncology.
Today, as part of the section on spinal oncology, we're going to discuss collaboration with medical oncology and also discuss the impact of evolving therapeutic options in systemic therapies for cancer. So welcome and thanks for joining us. So Joshua, I thought we could lead off with asking you, how do you prepare patients for surgery and how do you decide whether to take someone to the operating room, someone who has metastatic cancer to the spine?
I think the most important thing in looking at and making that decision about whether it's time for surgery or not, I guess the simplest cases are the one where somebody presents with profound neurologic deficits. You know, that's sort of an easier answer in terms of what your options may be. But the more complicated patient is a patient who doesn't have that. They have a metastasis in their spine identified. It is in that intermediate instability sort of framework. So I think one of the things you can use, focusing on how do we collaborate with our colleagues in a cancer center is to present at a tumor board. Look at the patient's overall status, look at what therapies they have been on. Are they newly diagnosed and have excellent treatment options? Are they a recalcitrant recurrent tumor that has been through multiple lines of therapy who might not be expected to have a good response or a great response even to medical therapy? So I think really incorporating the medical oncology team is really essential. And if you review the NCCN guidelines in any tumor type, one of the first steps is review with a multidisciplinary tumor board. So I think that's really germane to what we do as well.
I was just going to ask, what are your thresholds that you use? You mentioned the neurologic deficit is kind of an easy one, but I think that there are some times when patients kind of fall into that intermediate category where they may be in, an Asia D, let's say, some mild weakness or whatnot. And I think, I've seen different ways that people kind of approach that patient population, different from somebody who's just completely out and paralyzed.
Yeah, I think that to me, I really look at that patient and try and assess what are their symptoms. One of the things I probably let guide my decisions the most is stability. Mm-hmm. And obviously we have lots of different grading systems for evaluating stability. But to me, I think one of the best clinical assessments of stability is just ability to be comfortable with upright positioning. Mm-hmm. So if a patient can sit up and stand up for x-rays, that's a different patient than the patient who is fine when they're supine, but literally can't stand up because of pain and instability, not just neurologic issues.
Yeah, I agree with that.
That's a great point. And I think going back to what you mentioned earlier about the multidisciplinary nature of the conversation with the other specialists, I'm just curious, are there specific things that you typically ask your medical oncologist or that you want to know from them when you're thinking about taking these patients to surgery? There are a lot of things that we consider, their neurological status, the stability, but when you're thinking about the extent of cancer or their condition, is there something specifically that you often typically in your day-to-day practice would ask them?
So, the classic answer to that is going to be overall prognosis. Do they have a prognosis of 3 months or more as a number we use historically? I think that there's pluses and minuses to sticking to that number, but really more so than that, because frankly that's a guess a lot of the time, an educated guess, but really still a guess. Yeah. Is really looking at what medicines are the people on. Are they on things that are going to interfere with, is it an angiogenesis inhibitor that's actually going to inhibit healing of the wound? Forget about bone fusion. Can I even get the wound to heal? Have they finished radiation within the last 3 weeks? Those are some of the things that may drive me away from an immediate operation that I kind of rely on them to help me with.
Yeah, I was going to say similar. I found that one of the things that I like to try to clarify is what line of therapy that they're actually on in their overall disease course. And I think going back to your point about prognosis, it's a good way of trying to see, hey, what are the options available for a given patient? The person who's, hey, this is, de novo disease, this is their first line treatment, is very different from the one who's on their like fourth or fifth agent and has been, recalcitrant to all those, kind of like what you were saying. I think the other thing that I've also been, I think, erred more towards surgery is those cases where they're candidates for immunotherapy or some other kind of targeted agent that can, be specific. And sometimes, for the surgeries, especially since we're able to do the biopsies at the same time, you can send it for any kind of sequencing or genetic testing to figure out if there are actionable markers that can actually result in a better targeted therapy for a patient. So, along that same lines, I in general ask that same question in terms of I use those as kind of surrogates for prognosis because I think they kind of get at the same, answer of, is this somebody who's gonna, be able to tolerate your surgery and basically is gonna have, potential options after.
Yeah, that's a great point. And the follow-up to that is you've done a lot of work in molecular genetics. Do you think the molecular profiling of these cancers, do you think that is going to be more part of surgeons' decision-making process in these situations?
Yeah, personally, yes. I think, one of the things that you can see if you look at a lot of the brain tumor literature, if you look at a lot of I think the oncology literature in general, you're seeing things being defined by their mutational status, by mutational burden, by the receptors. For instance, it's not in lung cancer, it's not if you have non-small cell lung cancer, it's, do you have an ALK positive, EGFR negative, cancer, MET negative, those things. And I think that in the same respect, you've seen a lot of that transition as we've been doing a lot more of these sequencing paradigms. With that in mind, in the future, we could see the same thing as when we look at spinal metastasis. If there's a difference between, for instance, an ER positive, PR positive breast cancer patient and one that has a ESR mutation, right? And the way that you can treat those two patients may be different, both in terms of the radiation therapy, in terms of surgical decision making, and then even just what you can do with them. Kind of going back to your whole point about prognosis. So.
Yeah, I think I would completely agree with that. I've sat down with my pathologist, and he truly believes that we are heading directly towards where we are not doing histologic specific treatments anymore. It is all about next generation sequencing, whatever particular, spectrum or assay your hospital does, that's what's being used to target things. And yes, an EGFR blocker maybe, was found in lung cancer, but if you have a colon cancer that has that same profile,
right,
that's what you're going to be put on. And I think we're even seeing that move into the sarcoma world. Same thing with a lot of our sarcomas, we're treating it much the same way. And I, again, completely agree with you that what we do and how we treat people matters. I'm already to the point where if I have a breast cancer patient who is ER, PR positive, I am extremely likely to do a less invasive separation surgery type approach to them because all I need is to clear their cord and let them get radiated and they're going to heal like gangbusters.
Exactly.
Whereas if I have a triple negative breast cancer who's recalcitrant to multiple lines of treatment, I may, go to directly to like a spondylectomy.
Yeah. And it's funny that you bring that up because I think, that has implications for your earlier comment about, multidisciplinary tumor board and the benefit of that. I know that those of us who kind of do this more frequently, we are more versed in all of these. And I think that, as time goes on for surgeons who may not be as, familiar with all these kind of molecular targeted therapies or, mutations and whatnot, whether or not, they're able to get that information to make those effective decisions is going to really come through a tumor board because I think, that's where people are going to be able to go over all these things and do it. So.
Yeah, these are all excellent points. Really excellent points. And one thing that I will share that I learned in my own journey as being a spine surgeon that takes care of a lot of cancer patients is I realized that sometimes the medical oncologists, even though we defer to them, they don't really know either. And they're also sort of making a best guess on prognosis because many of these patients, regardless of the histology, many of these patients in the treatment trials, patients with bony or spinal metastases are often excluded from those studies.
Yeah.
And so there is not great data, and we have retrospective surgical series looking at that, but there are areas where there are just common knowledge gaps. And so I think the points that both of you brought up today really highlight the challenges and where we are today in terms of discussing with medical oncology, but also realizing that on both sides, there are areas of uncertainty.
One of the other things I was thinking as we started talking about this is, what are the ramifications from what do we do as surgeons based on that molecular targeted therapy, and kind of, I think, you recently had your paper that basically showed that, fusion rates basically are not necessarily the goal of fusion shouldn't be something that we try to aim for in the metastatic spine tumor population, right? Because of survival, because of, all of those different things. And one of the things that, we may see is that in the future, maybe that paradigm shifts, in that if somebody has let's say an ER positive, PR positive, maybe that's the person that you do try to put, some kind of arthrodesis type material or allograft in that would actually promote fusion, because that's the person who's going to do the long-term survival. And so as you think about kind of costs and how you can use your tumor board recommendations, your genetic markers, all those things to kind of influence some of that decision making of what we actually do in the OR. I was just thinking, from your perspective, just thinking about that paper of kind of how it's very, very timely now. But I guess my question to you is, in the future, how do you see that kind of evolving?
I think that in the future, when we have therapies like this, we may not be radiating all these patients post-operatively.
Yeah.
When they have a predictable, significant PR or complete response, maybe we don't need radiation.
Yeah.
Well, thank you for the great discussion. Please look for more content from the NAS section of Spine Oncology.